We have now this coronal section, quite ventral, which shows primarily the left lobe of the liver. Note that it sits just above the stomach, which has some contents. And below both, we see in dark green the transverse colon. So the left lobe has inferiorly the stomach, and below the stomach is the transverse colon. This radiograph shows barium in the stomach, small bowel, and large bowel. Because the left lobe of the liver has no fat outlining its inferior portion, nor above it, because we see the heart above the left lobe of the liver, it is not possible to note the boundaries of the left lobe on plain radiograph. We must use indirect signs, which are particularly the displacement of the stomach and the displacement of the transverse colon. So when the left lobe, which is seen in the midline of the abdomen, enlarges in the craniocaudal direction, it will displace caudally the gastric antrum and secondarily the transverse colon. This is a very spectacular case of a youngster who on physical examination revealed a mass palpated in the epigastrium. Contrast studies were ordered, and we are showing you the stomach, the colon, and a close-up of the upper urinary tract. Note that there is displacement of the gastric antrum caudally. Also note that the small bowel rises quite highly against the right flank of the patient. Note also in the barium enema that the ascending colon is close to the midline, and there is also a low position of the proximal transverse colon. In the urogram, the right kidney has reached the right dome of the diaphragm and appears much larger than the left. Note that there is a small left pelvocalyceal system, and we can also see a diverticulum of the proximal left ureter. So in summary, this patient had multiple anomalies which caused abnormal positions of the stomach, small bowel, large bowel, and kidneys. These two images show scintigraphic examination of the liver above and a celiac angiogram below. Scintigraphically, the left lobe appeared much larger than the right, and this is distinctly abnormal. This is not what is to be expected in an adult. Also note that in the injection of the celiac trunk, there is inversion of the trunk in the sense that the takeoff of the common hepatic artery and splenic artery come from the caudal part of the celiac trunk, not from the cephalic portion of this artery. Also note that the left hepatic arteries are much larger than the right. In none of these two studies, one could see a focal abnormality in the left lobe of the liver. This was simply a hypertrophied left lobe of the liver. These are late phases of an angiographic examination. Both the celiac artery and the superior mesenteric artery were studied in this patient. One can see the high position of the right kidney and the uniform opacification of the liver. There was no increased arterial supply to the liver. There was no evidence of a diffuse or focal liver abnormality. Here we see a selective left renal arteriogram. Note the abnormal shape, size, and position of the left kidney. The axis of the kidney appears tilted with the upper pole more laterally located than the lower pole. Note also a hypertrophied left adrenal gland. This patient had at birth a mass around the umbilicus, which proved to represent an omphalocele. And when the surgeon operated on this patient, already the left lobe had hypertrophied. The right kidney did not find the obstacle of the right lobe of the liver. That's why it rose all the way to the right dome of the diaphragm, And on relocating the liver into the abdominal cavity, this patient was left with a markedly developed left lobe and a hypoplastic right lobe of the liver. In addition, there were other anomalies, as we have described, of the kidneys and of the adrenal gland. So this is to remind you that whenever we see an epigastric mass, either radiologically or when clinically the mass is palpated in the epigastrium, we must always think in an enlarged left lobe of the liver, which either may represent an anatomic variation or a pathological condition. In reference to omphalocele, complications include malrotation of the bowel that may predispose to intestinal obstruction from a volvulus, abnormalities of the hepatic position and shape of the liver, which may cause gastric outlet obstruction, and angulation of the inferior vena cava at its junction with the right atrium may cause intermittent vena caval obstruction and difficulties in catheterization. This patient did not have any surgically treatable condition. There was only an anomaly, a group of anomalies which were the result of herniation of the liver and development of the liver in an umbilical sac due to the presence of an omphalocele. And the baby was treated surgically, but at a time when already the anomalies of the position of the kidneys and liver had taken place. When a liver enlarges, the left lobe can reach the left abdominal wall and grow laterally, cephalically, and caudally. It can almost embrace the spleen. And in this patient, there was a defect in the region of the spleen, which was initially misinterpreted as possibly representing an area of splenic laceration. This second level of the CT examination shows that the density was a space between a left lobe of the liver that embraced the spleen and a normal spleen. We have seen similar abnormalities in patients with diffuse fatty metamorphosis of the liver, and occasionally even with congestive changes such as Budd-Chiari syndrome. The left lobe can become so large that it will wrap around the spleen and mimic a left upper quadrant mass. This is a very spectacular case of a patient who presented with vague abdominal symptoms, and on the frontal chest rentgenograms we see a mass in the left lower hemithorax. What is a differential diagnosis? We must consider a pulmonary lesion. We could consider a pleural abnormality that can either be a fusion, subpulmonic, or a pleural mass. One has to consider a diaphragmatic tumor or a subdiaphragmatic process, be that a fluid collection, the enlargement of an organ, or a tumor. A left lateral view of the chest was non-contributory. We can see just a mass in the left lower hemithorax with a little blunting of the left costodiaphragmatic angle posteriorly. We're going to show you now 4 images of an upper gastrointestinal barium study. Note in the prone position that the fundus of the stomach is abnormal. It appears concave superiorly instead of the normal convexity that we should expect. Because of this appearance, the diagnosis was inversion of the diaphragm due to subpulmonic effusion. The supine examination of the stomach confirmed the presence of a supragastric mass, and this image was again considered to be very suggestive of inversion of the left dome of the diaphragm, probably due to a pleural effusion or a supradiaphragmatic mass. A prone right anterior oblique examination of the stomach showed extrinsic pressure at the level of the fundus. A right lateral examination of the stomach showed that the fundus and body were displaced dorsally. And the only organ that can do this is the left lobe of the liver. A phagocytic liver scan did not reveal what was going on in the left upper quadrant. It showed the normality of the right lobe of the liver, and poor uptake was noted at the level of the superior aspect of the left lobe of the liver. The next two images are of a selective hepatic arteriogram, the early and the late phase of the study. In both, note the prominence of the left hepatic artery, which supplies a mass in the left upper quadrant and left lower hemithorax. Note the neovascularity that exists in that mass. The diagnosis, therefore, is a tumor in the left lobe of the liver, which proved to be a peripheral form of cholangiocarcinoma. So this is to show you that the left lobe can enlarge caudally, laterally, and superiorly. So whenever one sees pathology of the left upper quadrant or even in the left lower hemithorax, always consider the possibility of a process involving the left lobe of the liver. This is a patient who had a partial gastrectomy, and on contrast studies of the upper alimentary tract, a very high position of jejunal loops was observed. Was this due to a technical surgical error, or could this represent an anatomic variation? A CT of the abdomen revealed agenesis of the left lobe of the liver. Note that to the left of the right lobe we see the gallbladder, and we see to the left of the gallbladder the bowel and the remaining portion of the stomach. So agenesis of the left lobe will cause organ relocation. And in this case, the bowel tends to occupy the space of the left lobe of the liver. I have divided the liver into the clinical lobe and the radiological lobe. This obviously is an arbitrary classification. And the reason I consider the clinical portion of the liver the left lobe is because it is easily palpable in the epigastrium. It is not covered by bony structures, and it is difficult to recognize radiographically because of the absence of a fat liver interface. And only indirectly we suspect its enlargement by observing a density that displaces caudally and to the left the gastric antrum and the transverse colon. In contrast, the right lobe, I consider it to be the radiological lobe of the liver. Why? Because superiorly it can be recognized by the aerated lung against the right dome of the diaphragm. So elevation of the right dome of the diaphragm is usually the result of cephalic growth of the right lobe of the liver, either because the dome is displaced superiorly by eventration or by hepatomegaly. The hepatomegaly can be diffuse or focal. The inferior portion of the right lobe of the liver has a fat interface between the liver and the kidney, and the retroperitoneal fat that covers the outline of the kidney and the visceral surface of the liver allows one to see the hepatic angle, which is also depicted by the fat of the right flank. So radiographically, we should be able to see the superior margin of the right lobe by the aerated lung above it, and inferiorly, we should be able to recognize in well-exposed images the presence of fat outlining the inferior margin of the right lobe. So radiographically, one can characterize a better hepatomegaly involving the right lobe than the clinician, who only can feel the liver extending below the right rib cage, and by percussion the increased dullness of the right upper quadrant when the right lobe enlarges. So it is easily depicted, the hepatomegaly of the right lobe, by radiographic technique, chest and abdominal studies, and clinically the left lobe is easier to detect by clinical examination than by radiographic techniques. In this coronal image of the abdomen and chest, one can see the right lobe in contact with the right dome of the diaphragm, and below it we can see the right kidney and the retroperitoneal fat. This is a sagittal section of the right upper quadrant where one can see the dorsal inferior concavity of the visceral surface of the liver, and the right kidney is separated from the liver by the perirenal fat. So we can anticipate that enlargement of the right lobe will displace downward the gallbladder in front and the right kidney dorsally. In this coronal MR section, one can see the bright signal of the perirenal fat and the black signal of the air in the right lung. So note that radiologically we can easily study enlargements of the right lobe of the liver by the fat below it and the air above it. This is a radiograph of the abdomen of the wife of a dear friend of mine who presented at the age of 48 with anemia. The abdominal study shows enlargement of the right lobe of the liver with a downward displacement of the proximal transverse colon. And as we shall see later, there was a caudal displacement of the right kidney. Note also that the stomach is displaced superiorly, and this was thought to be due to an enlarged spleen. One could not see well the outline of the left kidney, and the mass noted to the left of the stomach was misinterpreted as an enlarged spleen. Although this woman had no symptoms referable to the urinary tract, because a splenic pulp aspiration study and a bone marrow investigation were neither definitive to diagnose the cause of the anemia, a urogram was performed, and it shows that the right kidney is normal in size and structure, except that it appears caudally displaced by an enlarged right lobe of the liver. Note that the left kidney has a bifid collecting system, and it is markedly enlarged. Selective left renal arteriogram shows a cancer of the left kidney with the typical neovascularity observed in the majority of renal cell carcinomas. This patient mass in the left flank was due to an enlarged left kidney, not due to the spleen. A late phase of the selective left renal arteriogram shows evidence of left renal vein thrombosis, and note the collateral circulation around the lower pole of the left kidney as indicated by the arrows. Note also a hypervascular mass medial to the upper pole of the left kidney that represents metastatic nodes due to the cancer of the left kidney. These are two images of an angiographic examination. Note that there is no neovascularity in the right lobe of the liver. The right lobe of the liver is enlarged, and that explains the displacement of the right kidney caudally. Note also that there is a mass to the left of the spine that was due to the enlarged left kidney with the cancer, and that the spleen is not intrinsically enlarged. There is a deformity of the undersurface of the spleen due to the cephalic growth of the tumor and the enlarged left kidney. So this patient did not have splenomegaly. The left upper quadrant and left flank mass represented the cancer of the left kidney, and the enlarged right lobe of the liver was not related to metastatic disease. At postmortem examination, a large tumor of the left kidney was confirmed, and it is to be remembered that anomalies of the kidney, particularly of the pelvocalyceal system, are often associated with cancers of the kidney. There was no evidence of metastatic disease to the liver. The reason for the hepatomegaly and some abnormal liver function tests in this woman was the presence of the hepatic dysfunction syndrome, which is one of the manifestations of renal cell carcinoma. There are several systemic effects of a renal cell carcinoma. The general symptoms are fever in 17%, malaise, and weight loss. Hematological abnormalities include anemia in 33%, elevated set rate in more than 50%, and polycythemia, which is the opposite of anemia. The hepatic dysfunction syndrome has been described in 10 to 15% of renal cell carcinoma. And it is believed to be related to some material produced by the tumor that chemically affects the liver. Upon removal of the cancer, the liver may return to a normal or almost normal size, and the abnormal liver function test will return to normal findings. In addition to hepatic dysfunction, we may see elevation of the serum phosphatase, both the alkaline as well as the acid. There may be amyloidosis in 3 to 5%. Neurological manifestations have been described, as well as endocrinological manifestations such as hypertension in 10 to 25%, polycythemia, the presence of hypercalcemia, and the presence of protein-leucine enteropathy. Immunological abnormalities can be observed also with renal cell carcinoma. This is a very interesting report published in the Proceedings of the Mayo Clinic many years ago of the Stauffer syndrome, a syndrome which is hepatic dysfunction related to hypernephroma. And it also describes the reversibility of the liver insufficiency upon removal of the kidney's cancer. This is a very interesting patient that was sent to me from Texas, a 14-year-old young girl who had a mass to the right of the spine. This frontal chest rentgenogram shows an oval-shaped mass close to the right dome of the diaphragm in its medial portion to the right of the spine. A chest rentgenogram taken 9 years before, when she was 5, showed some sort of dextrorotation of the heart and an ill-defined density at the same site where a mass was seen 9 years later. A lateral chest rentgenogram at the age of 14 shows that the mass projects just behind the heart in front of the spine. A penetrated view of the thoracolumbar region shows the oval-shaped mass, almost looks like an egg, surrounded by air. That's why we see the right margin of the mass that projects at the level of the medial aspect of the right dome of the diaphragm to the right of the spine, and somehow it overlaps slightly the right side of the lower thoracic spine. In other words, it is in the chest, it is close to the diaphragm and to the spine, and the upper and lateral margins of the mass are surrounded by aerated lung. What's the differential diagnosis? We must consider the possibility of a bronchopulmonary sequestration, some sort of a congenital lesion, because this patient at the age of 5 already that mass was seen, and the patient was totally asymptomatic. Another possibility would be some sort of a mesenchymal tumor of the mediastinum, perhaps some neurogenic tumor. It could be some bizarre herniation or partial herniation of the liver, perhaps through a defect in the dome of the diaphragm, post-traumatic perhaps. All these were possibilities, and they wanted to do surgery because of the inability of establishing the nature of this mass. I requested 2 studies, a CT and a scintigraphic examination. A non-contrast CT study shows the oval-shaped mass with the same density as the liver. When contrast was injected, one can see the uniform opacification of this mass with the same density as the liver, and the liver appeared structurally perfectly normal. A phagocytic liver scan was ordered, and my dear friend Bill Smoke told me that in the frontal projection no abnormality was observed, perhaps some sort of decreased uptake in the region of the porta hepatis, but that there was no evidence of uptake of this mass by the isotope. I asked Bill to do a lateral image with the patient standing. A lateral image of the phagocytic liver scan shows uptake by the mass that was obscured by the upper portion of the right lobe of the liver. So there was no question that by the CT study and the phagocytic liver scan that this is a normal hepatic tissue. So my recommendation to the parents of this child was to leave the child alone, that there should be no surgery, because we had proven by non-invasive imaging modalities the presence of what I considered an example of intrathoracic accessory liver. I had seen a previous case that I will now show you. This case was shown to me at a CPC, I believe, of the Penrose Cancer Hospital in times of my dear friend Juan del Regaro. And it is of a 5-year-old child who presented with dry cough, and the chest rentgenogram was ordered and revealed an abnormality in the right base. The frontal chest rentgenogram revealed an ill-defined density at the level of the right cardiodiaphragmatic angle. Note that we see that the right dome of the diaphragm appears intact. A frontal tomogram of the chest revealed a slight lobulation at the level of this mass. There was no evidence of calcium, nor evidence of radiolucency indicative of fat at the level of the mass. A lateral chest tomogram shows the prevertebral position of this mass, which is adjacent to the right dome of the liver, and it is obviously behind the projection of the heart. The upper margin appeared slightly lobulated. A thoracotomy was done, and a paranephric mass, 0.4 by 1 centimeter in diameter, was found almost entirely within the lung. The arterial pedicles and a large vein crossed the diaphragm and were connected with the mass. The patient had a horseshoe kidney and anomalies of the ribs. This is a histological section of the tissue that was removed and showed normal liver. The final diagnosis was intrathoracic accessory liver. There are very few patients reported in the literature with this abnormality. Apparently, liver cell cords grow around hepatic veins that drain in the juxtacardiac portion of the inferior vena cava. And those liver cell cords can grow as nodules, and they may or may not relate to defects in the dome of the diaphragm. Usually there are several holes in the medial aspect of the right dome of the diaphragm that allows hepatic tissue to progress into the chest. The important thing to remember is that this is a mass that is not paraspinal, and therefore one should not suspect first a neurogenic tumor or a sequestrated portion of the lung, and that the best way of showing the presence of hepatic tissue is to do a phagocytic liver scan or do a CT that will reveal that we're dealing with a benign nodular mass that represents the liver. This is another case that was shown to me in a CPC some years ago. The frontal view of the chest shows a spherical mass adjacent to the right dome of the diaphragm. Note in the lateral view the projection of this mass above the diaphragm. The mass had no calcium, and then the differential diagnosis had to include the possibility of a hamartochondroma, the possibility of a benign lung mass such as a granuloma, an adenoma, a low-grade malignancy or an adenocarcinoma of the lung, for example. The possibility that this could be a pleural tumor, perhaps a fibrous mesothelioma, a tumor that may arise from the diaphragm, benign or malignant, or a subdiaphragmatic process. I was not told when the film was shown to me that the patient had received trauma to the right upper quadrant. I could not see fractured ribs. That would have been a clue that we are dealing with the possibility of transdiaphragmatic liver herniation. Liver sonography in these four images reveals some irregularity of the right dome of the diaphragm. In these four views, we can see a defect in the right dome of the diaphragm. So we should always look for continuity of the echogenicity of the right dome in a normal individual. In this case, that defect was compatible with a ruptured diaphragm and with the herniation of liver tissue above the dome of the diaphragm. A CT examination revealed the same appearance of the mass as it relates to the liver and the contiguity of the mass to the right lobe of the liver. A phagocytic liver scan shows some lack of homogeneity of the uptake at the level where the diaphragm had ruptured and liver had herniated. Remember that the lateral image on a scintigram may reveal liver tissue above the diaphragm that is not seen in the frontal projection. So this case, in summary, represents an example of a transdiaphragmatic liver herniation simulating a lung lesion or some sort of another mass that one would never think initially in the possibility of liver. On the left side, remember that the spleen can grow in the pleural cavity or even within the lung whenever there is a fracture of the left rib cage and there is rupture of the diaphragm. And this entity is called on the left side the splenosis. And whenever one sees nodules adjacent to the diaphragm on the left side, look at the history. If there is a history of trauma, it may represent splenic tissue above the left dome. On the right side may represent liver tissue above the right dome of the diaphragm. The lower margin of the right lobe of the liver is usually straight or gently concave caudally and medially. So whenever we see a convex apparent inferior margin of the liver, we must suspect either a tumor of the liver or some other type of pathology. In this patient who did not have high blood pressure and presented with vague abdominal pain, there was a palpable right upper quadrant mass. Also, a calcification was seen in the left upper quadrant. As we shall see later, the calcification was rounded and it was misinterpreted as a splenic artery aneurysm. We could not see adequately the outline of the kidneys in this scout film of the abdomen. An intravenous urogram was ordered because the patient had the dysuria. Note that the left kidney is normal, but we do not see the right kidney in the usual position of the right flank. We note a second pelvocalyceal system below the left kidney. So this means that the right kidney either had a cross-renal ectopia, in other words, it was fused to the left kidney on a congenital basis, or that it was displaced by a retroperitoneal mass. And then one must suspect that the right upper quadrant mass may not have been related to the liver, but to something dorsal to the liver. A CT examination revealed that the mass was hypodense and did not correspond to the right lobe of the liver. The entire liver was displaced to the left of the midline and cephalically by a large retrohepatic mass. The calcific density noted close to the midline within the liver shadow represented a solitary gallstone. So also the gallbladder was displaced by the retrohepatic mass. Whenever we see displacement of intra-abdominal organs, and particularly the right kidney appears displaced towards the midline or crosses the midline, the origin of the mass must be suspected to be in the retroperitoneum rather than represent an intra-abdominal organ, because an intra-abdominal organ cannot displace the kidneys across the midline. In this same patient, a lower CT cut shows the right kidney displaced towards the left and in front of the aorta. At surgery, this patient proved to have a non-functioning pheochromocytoma. So the mass was a large adrenal tumor. Adrenal tumors, tumors of the kidney, and other retroperitoneal tumors can mimic hepatomegaly. This is a CT examination of a professor of radiology who noted the presence of gynecomastia. He was not taking any hormonal medication or any type of medication such as digitalis to explain the gynecomastia. One of the considerations when a male presents with gynecomastia is a functioning endocrine tumor, and one should always look for the possibility of an adrenal tumor, and particularly for a carcinoma of the adrenal gland. The CT examination revealed the presence of a rounded mass that was palpated and was initially considered to represent an enlarged right lobe of the liver. Note that the mass is hypodense in contrast with a normal right lobe of the liver. A sagittal MR section of the right upper quadrant and right flank revealed a caudally displaced right kidney, a cephalically displaced dorsal portion of the right lobe, and the interposed lobulated mass between the undersurface of the liver and the upper kidney, and this lobulated mass proved to be an adrenal carcinoma. This is a case that was given to me by Dr. Hrichak many years ago. In this patient, we note that there appears to be an irregularly hypodense mass in what appears to be the right lobe of the liver. Is this really the liver? These are sagittal images of a sonographic examination of the right upper quadrant and right flank. And it shows what has been described a decade ago as the sonographic sliding sign. It revealed that there was a mass below the right lobe of the liver, and the displacement of this mass in inspiration and expiration is what was considered to be very characteristic of a subhepatic mass. This mass proved to be a renal oncocytoma. So a mass of the adrenal gland, a mass of the upper pole of the right kidney can mimic an enlarged right lobe of the liver. The non-invasive imaging modality that would often clarify the anatomic location and the possibility of the mass being a tumor is sonography. And sonography should be obtained in the ventral as well as in the sagittal plane, and the liver and retroperitoneum should be examined while the patient is doing inspiration and expiration. If we see that the mass slides under the right lower border of the liver, we know that the origin of this mass is not in the liver, but in the retroperitoneum or in the subhepatic region. Some anatomic variations can mimic adenopathies, and this appears on CT examination. We must complement axial images with sagittal images. So the prominence of the papillary process of the caudate lobe on some horizontal sections can appear as a rounded density at the level of the liver hilus. When we compare the horizontal with the sagittal images, we can then note the caudal projection of the caudate lobe, the so-called papillary portion that on horizontal sections appears as a rounded density mimicking adenopathy.